the Pediatric Lounge, a podcast taking you behind the door of the physician's lounge to get a deeper insight into just what docs are talking about today. From the clinically profound to the wonderfully routine and everything in between. Good morning, George. It's Tuesday morning and we have a wonderful guest today from Winfield, Kansas.
Yeah, today we have Dr. Todd Peters. His topic of discussion today is going to be a day in the life of a pediatrician in Winfield, Kansas. I think it's going to be, we're not in Kansas anymore, Toto. Take it away.
Yeah, you're right. Yeah, I'm Todd Peters. I live in Winfield, Kansas, and I just happened to run into Herb back. We were at a conference in Miami, and he said, we don't hear a lot from rural pediatricians, and hey, let's have a conversation. Why not? Talk about what that means.
Yep.
So I had the pleasure to meet Todd. Actually, it's a funny story in the restroom in Coral Gables at the Nichols Children's Hospital CME as he yelled out, "Hey, you're the guy from the podcast." But Todd is a former IT person that then decided he wanted to become a pediatrician. And he is out there about an hour south of Wichita, Kansas. And it's a pleasure to have you on the show today. Todd, we always start with the same question. Why did you become a pediatrician?
It's a good story. There's a couple of turns in my life. When I grew up, I was a lot like my father, and he was an internist. And I thought, he had some health issues. So I thought, I'm not going to med school, but I do like computer science and physics. So I went and got that degree. I got a computer science degree. And as I was working in the cubicle, I thought, you know what? I really like people, and I'm tired of sitting in a cubicle. Feel very lonely, and this is a long time. This is 30 years of my life. And so I decided, you know what, I'm going to start that journey towards medical school as a non-traditional. It was maybe 25 years old. Jump ahead to third year clinicals and med school. And I always thought, I'll probably be an internist or a family doctor. And I've always enjoyed kids. My grandfather and my dad and I were very much like just like the little kid when it comes to playing with the toddlers when like the family gatherings. And so when pediatric rotation rolled around, there was some good experiences and some like maybe experiences that say, you know what, you should be a pediatrician. My first night of call in med school was trauma for surgery. And I think it was 8-year-old child who was hit on his bike and had internal bleeding. It was pretty dramatic and sad. And then fast forward to fourth year, I did a pathology rotation, just something interesting. And the other sad story was that they had a miscarriage and they did an autopsy. So I got to see that end of it. It wasn't like the most fun part of it, but the main part I got to see was when I was doing the rotation, just the general peds rotation, I saw how happy the pediatricians were. And that's a general theme you guys talk about. And yes, there are days where it's not very fun, but there seems to be a lot of signs during med school where I saw those happy pediatricians. I saw the ones who work in the hospital and just all the things that they could do for the kids, and also just the pleasure they had doing it and how much they like to share their knowledge with the students and with everyone. The residents, they were on a higher standard, but and when it came to that, but we all really enjoyed doing that work. And I saw that and I really thought, this is a big commitment. This is 30 years of my life. I really want something I can enjoy. And I don't mind hard work, but I really had fun doing that.
And what kind of practice did your father run? I don't know if he's in practice still or is he retired?
Yeah, he's about 10 years retired. And internal medicine, he started out as a general internist. And so he had hospital rounds and clinic. And then I think when he was a teenager, so that would have been about halfway through his career, he switched over to doing more of the urgent care. And in Wichita is where we grew up. He had more of an internal medicine, just urgent care clinic. So he was doing more scheduled hours. And I think when you have teenage sons and a family, it's nice to have more predictable time. We really didn't see a lot of him prior to that. So that's what he did. A lot of was mostly clinical work.
And what is your practice like out there? Because it's a very small town. I looked it up and I think there's 11,000 persons in the whole town.
Yeah, Winfield is part of Cali County, and there's 2 towns, Winfield and Arc City, and they're each about, I'd say 13,000, but 11,000. So about maybe 30,000 people in the county. And we don't have a huge population to pull from. We have any rural community traditionally is going to be more poverty than, say, inner cities are poor too. We draw on a lot of different kids. There's some that grew up here their whole life. They're farmers. There are people we have a Micronesian population, which is a Polynesian, and they just don't. It's a very big language barrier. You'd think Spanish is also here. We have Hispanic families. We have a lot of meat packing in Arc City. So we have a diverse amount of people, but when it comes to numbers, it's pretty spread out. And just if you're going to go anywhere, you really need a car. Just there isn't any, the public transportation is not there.
Well, from my own ignorance, I would think middle of the country, everybody's white, wears overalls and drives a pickup truck.
There's a lot of pickup trucks. I don't drive a pickup truck, but there's a lot of pickup trucks.
Yeah.
There's plenty of white people too. You'd be surprised. I definitely don't see a lot of African Americans. There are some, but I don't know if it's just, we do have a college in our town called Southwestern College. It's a liberal arts, private liberal arts college. So we get 10 years ago, we got a lot of people from the Middle East, and now we don't get those grad students from like Saudi Arabia, but we do get a lot of first year football players, a lot of kids just from around the Midwest. My wife teaches at the community college, which is in Arc City, and we have a lot of athletes too, international. They aren't coming to see me, but we tried to, there is some diversity, but it's not, I've traveled some, but I am definitely not familiar with everybody's. We have our niche. When it comes to our patients, though, our hardest population is going to be the Micronesian. They're out west of Hawaii or way off past the international date line in the Pacific Ocean, and they speak a Chukis language is what it's called, or Chuk. I think it's Chuk. And there's also, I think, Marshallese, I've been told, which is a very similar culture. And yeah, you can't find an interpreter for that. You just hope either one of the children or one of the relatives can help bridge that gap when there is that big language barrier.
Did you end up in Kansas? Did you grow up there, or?
Yeah, I grew up in Wichita, and I was in Kansas City working, and I decided I was going to go to med school, and I applied for my state school, but with the plan of maybe going to a Midwestern DO school if I didn't go to the MD school in my state. And so I stayed here. My mother was quite sick when I graduated medical school, and I really wanted to be near her. And then I settled down, I got married, and my family's kind of spread out. A lot of people that live in Kansas, I think when they grow up, a lot of them want to move somewhere more. There's more jobs when you have a graduate degree, probably outside of the state of Kansas. So, yeah.
You went to school in Miami, so that's a really nice place.
I probably should. I did go to Denver for a year in college. That was nice.
And your office is at 3 exam rooms?
Yeah, we have 3 exam rooms. Before it was a nurse practitioner and I for the first 5 years. And so we split 5 rooms, and we used ECW at the time, and a family doctor that was north of us, about close to Wichita, he helped us bridge that gap. He's from the county, and he wanted to help keep those clinic connections. So we ended up, what happened was we had our VFC program kind of went south when one of our fridges died with that doctor. And so I ended up asking the hospital, could you help me? Because we haven't had our VFC vaccines for over 6 months. I don't know what's happening with that. So I wouldn't say I panicked, but I definitely was stressing out. When somebody has a refrigerator and it goes bad on you, it was just a regular store quality refrigerator. It was not a vaccine type fridge. So for half of my practice, I was in that setting where it was the 5 rooms, and then the other half was more just me in 3 rooms. I do have one nurse practitioner kind of covers us on the Monday. We kind of overlap because that's the busy day when a lot of people are trying to get in and we can't squeeze them all in. And that's really what clinic is about. We have me, we usually have a receptionist and either a nurse or an MA. That with COVID, it's really, I think a lot of people have said this too here and other podcasts, or just in general with getting staffing. It's been a struggle. We definitely have a lot of turnover. And when you get somebody that is working great for you, we're always trying to just be there for them and support them, because next thing you know, they'll be gone to another job or something will happen. Yeah. So that's our setup.
And so you're now out of that one office most of the time, the 3 exam rooms?
Yeah, our office, it's attached to the parking lot for the hospitals. William Newton Hospital owns the clinic now. And at one time I thought about, would I be my own independent practitioner and I just do my own thing? And I just never had the guts, I think, to try that. You guys, your stories make me think about that and go, maybe it's worth the risk, but I don't know. There's just a lot of cost. We say this year we've only seen 55% Medicaid. is what my manager said when we went over the EMR data. But I think my nurse and I both think when it comes to vaccinations, it's like 70% probably. It's a lot higher. I think that data is probably not the one piece of data is only so good until you get more data, you just don't know. So I was asking her for the podcast to see what our current number was. Yeah.
And you're on Epic now, or what EMR are you on?
We're on Azalea. When I made that jump from working for the clinic with my old boss, Dr. Roush, we ended up going to Azalea, which is a company in Atlanta. It's a cloud-based, pretty simple like web form thing. There's linking and things, but it's not, I wouldn't call it anything like Epic or ECW where it has like as far as I can tell, I don't feel like there's as many connections being made behind the scenes. And one thing we really want to do is get these kids back in for their annual physical. And surprisingly, we asked if we could get a report, and there's not really a report that says, oh, when was our last visit? It's and I guess it's probably true. Like when you made your dashboard, it's very difficult to find some of that data without digging through CPT code after CPT code.
Yeah. Is that the hospital chose that? Like, is that system wide? That's what they use? Is that why you're on it?
Mm-hmm. Yeah. They had already had it for a couple of clinics. They were doing the clinics here. When in 2019, when I became an employee of the hospital, some of the other physicians were private practice. And then it seemed once I made that change, the administration was really open to that. And I trust the administration. A lot of people talk about how they're going to be careful because the administration of a hospital they are seeking their best interest. I know that. But when it comes to like the numbers and when it comes to, I think, wanting us to stay in this small town, I don't think it's true everywhere, but I think here they have been looking after my back. They don't want us to leave. They're not trying to surprise us. And there are other places around where we live around the Wichita area that I know a few other small towns, and they've had that where they worry about that one day they're going to employ a physician or the physicians in town are like working with the hospital. And one place started urgent care and said, look, we're going to staff it and we're going to basically promote this. And if you don't do one day a week at the urgent care, we're going to basically we're basically going to take your business, if you will. Not literally, but just they're going to make your life difficult. And I've never seen that in our Winfield. At one time, I actually was covering Winfield's hospital and Arc City's hospital as a pediatric for my patients. And after 2 or 3 years of that, I realized that there's a couple times a year where you may have a flu patient or an RSV patient, and you really can't get to 2 places at once. And there was no emergency that was dangerous, but that's something I had to consider too, living in a small town. And so after about 3 years, I said, you know what? I'm just going to keep my privileges at William Newton Hospital, the one that's across the street from the clinic. So I could run over there in the morning. I could run over there midday or afternoon. If an infant needs to be rounded on or circumcision needs to be done, it can get done pretty quick and get right back to the clinic. And there's no like loss in continuity for the most part.
The hospital better be nice to you because you're the only game in town. If you're not there, they got nobody. So they should roll out the yellow brick road for you.
They have been very nice. I've heard you talk to someone like, these people that talk about when you graduate, how to do well in terms of like contract negotiations, work in a rural place or a low cost of living area. And I didn't intend that at this time. When I was graduating from residency, I was just looking for a job in Wichita. And we lived in a southern suburb of Wichita in Derby. And I just happened to stumble on this job. Our university has a rural hospital or rural healthcare job board for the whole state, like a free way to avoid these small communities having to pay for headhunters. Mm-hmm. And so it's a job board, and I found something on there, and I just went with it, and it happened to be a good opportunity. One of my med student colleagues, she was an internal med resident, and she had worked here in the ER and said good things about the people and the staff. And so I had some good credentials, some good leads to go with versus just me going blindly into a new place and taking a job for 10 years.
Yeah. So, and what's your hospital like? Does the Wizard of Oz live in there?
Yeah, we have gold sidewalks, the yellow brick road. We have so it's a critical access hospital, and it's 25 bed. We have up to about 5 newborn postpartum rooms. And so usually there's about 250 babies born a year. So it's not a ton. And we have family docs that round on their babies. So I'm not doing newborn all the time. A couple times a year, I'll get called in the middle of the night to go to a resuscitation, emergency delivery. But for the most part, and if we have that problem, we stabilize the child and always ship them. We don't have a level 2 nursery or anything like that. In fact, we didn't really have any nasal CPAP here until we have high flow nasal cannula, but not nasal CPAP for infants. We just got that probably 3 years ago. So I've been asking for it for a while, but you just have to wait sometimes, I think, and keep nudging people.
Do you have to go to C-sections?
Not required. If there's a high risk one, the obstetrician will contact me. We have 3 OBs they're in one clinic, 2.5 full-time people, basically.
So if there's a premature baby, because ultimately there's going to be a premature baby 28 weeks or something.
Yes.
Born. You have to manage that.
We ship them to the NICU.
We have to manage it until you ship them to the NICU.
Yeah, we had the first week I physically moved here from about 9 months into my job here, we physically moved to town. And that Wednesday night, they had a 26-week, they thought it was an abruption and they weren't 100% sure. They couldn't confirm on the ultrasounds. They delivered the baby and we stabilized and then shipped them. And it was not an abruption, thank goodness.
Wow.
But you think it would be more often. I thought the first couple of years, we probably had 4 or 5 a year and maybe that on a busy year now. I feel like my skills, I got to keep them sharp. It's sometimes you don't do enough volume to really, you have the skill set. It's just not as your motor memory is not as
you lose it after time.
Yeah.
That's one of the most difficult parts of it. You're absolutely right that you've done it, you know how to do it, but a year goes by, you don't have to intubate anybody.
Yeah.
And you might still remember, it's like riding a bicycle, but your confidence level goes down.
Yeah. Now, what happens if they call you, a kid shows up? I would predict that there has to be a kid that drowns.
They usually
show up and they end up in the emergency room. Do they call you for that?
We monitored if it's a full drowning where their Glasgow coma scale is affected, they're going to go to the ICU, like a PICU in Wichita. Yeah. And usually they'll just do a direct transfer from the ER.
Oh, so you don't get
somewhere is like a near drowning and we'll watch them overnight if their vital signs are stable. But
so you have to leave the office and do the admission.
I've been very fortunate. Usually if there's an emergency during clinic hours, it's a newborn, it's a delivery.
Uh-huh.
And the ER has been very good at managing most of the patients that they have.
Yeah. But I predict they don't have pediatricians in the ER.
Oh, no. There's a lot of them.
I'm asking for a lot.
They're like new residents. And some of them, I think they get surprised. We try to tell them, look, this is a little bit busier ER than some of the other rural ones you've been to. And we're trying to keep them here because we don't want to burn out anybody. But it's a good experience for them, too. They see a lot of variety, I think.
Who manages the residents?
These are actually like third-year family residents, or they can moonlight, basically.
But somebody has to manage them. Somebody has to be responsible ultimately for them.
We have a director of the ER.
Okay.
He's a family doctor here in town, and he's done ER a long time in urgent cares, and he's been the director for a long time now, at least probably of the 10 years I've been here, 11 years, he's 7, 8 years of that, if not more.
Wow.
Yeah, we're fortunate. Kid has a seizure or something. A lot of times they just get stabilized and sent to Wichita because we don't have those specialists. The one time we might use a subspecialist is if we have a newborn, we needed a chest tube one time. And so we called the NICU, and it had been a long time since I'd done a chest tube. So myself and the ER physician were up in the resuscitation room, and we just stepped through it with him. He had done some chest tubes on adults, and I had done a baby chest tube in probably 10 years. So we stepped through it with the neonatologist on the phone. And sure enough, we just had that tube in place, and we did every half an hour, we would just decompress it. It was just one of those weird days where we had at least 3, I think, that were unstable enough to be put in a NICU. And it doesn't happen that often. Maybe once a year, maybe every 2 or 3 years where you get that kind of, this is just a busier night than we're used to.
Wow.
And when you transfer these patients, do they fly a helicopter out, or they send a bus to pick them up?
Yeah, the NICU, both NICUs in Wichita, they tend to they have their modified ambulance where they have all their CPAP and their IVs and things like that for the infants. So We've gotten a flight once. I had a child with a cerebellar tumor, and it was just one of those things when you realize what's going on, you stop everything and you call anybody that can help you because this is a serious problem. And Children's Mercy is in Kansas City, and they flew down there's an airport, I don't know, 10 miles outside of here. So they have their jet they could transport. When I was training, one of our attendings was out in Hayes, Kansas, which is like 4 hours, is 4 or 5 hours to Denver, 4 or 5 hours to any city that's a major. And they had to sometimes ship kids that were like, oh, they might have meningitis and we aren't sure we're going to get this started, but we need to get them on a plane ASAP. We aren't quite in that situation here. Usually it's more ground transport.
So basically, you have to manage the case until help comes.
Yeah. And
which could be 2 hours, 3 hours, 4 hours.
Doctor George.
I know. I'm starting to feel like I don't work.
That's right.
I was on call last night. I got one call at 1 o'clock in the morning for some nonsense. Then I couldn't sleep until 5.
Yeah, that is the worst. But that's a function of age. Like after 40, if you get woken up in the middle of the night, it is a bear to go back to sleep.
Yep.
And these are the stories. These are more of the exciting stories from the last 11 years. It's not a common thing.
I think you're downplaying it. You're a hero, friend.
So my wife tells me, I'm like,
you're downplaying it because I can't out here on Long Island, cushy Long Island. People don't want to go see their well babies in the nursery. You're talking about taking helicopters with premature babies.
Yeah.
All right. A little different.
Putting chest tubes in kids
it's a little different than my day-to-day work.
Yeah. That was the ER, the doctor that ended up doing it physically. I was like, you've done this in the last 12 months. I have not. And I said, I'm here. I will help you if I can. But I think that we're all on board. And there was a family doc there too. We're like, you're the guy. Because he was, I don't know, in pediatrics, when it comes to procedures, it's not I think if I was a proceduralist, I probably would have chosen a different pathway because I'm decent with my hands, but I am not the surgeon hands. I knew I wasn't my skill set. So I do what I can.
What do you do for subspecialty support? Because practice in a rural area, probably more rural than what you're describing. And I always felt guilty sending some kid for an hour and a half drive to a specialist. So the specialist says, oh, no, there's nothing to worry about it. You wasted your whole day driving out here for nothing.
Yeah, I try to if I can use imaging, say somebody's vomiting and I can do an upper GI or something, and I think it's a decent alternative, I do that. We have no sleep specialists anywhere. It's 3-hour drive for any kind of sleep evaluation for anyone under 12. And so a lot of times we're sending them to ENT, which we do have coming to town. It's all outpatient once a week. But yeah, you're right. We send a lot of kids they go to the cardiologist. It's got to be an hour trip each way. And I wouldn't say I refer some, but you do have that discretion where you're like, you know what, we're going to come back. We're going to check this out in a couple of days. We don't need to do anything now. Let's come back in 2 months or a month. It's difficult though. I didn't know that you did rural practice too.
I did for 3 years in Lebanon, Virginia. It's a small community, coal mining country in Appalachian, Virginia, critical access hospital. They recruited me so they could restart their maternity ward.
Mm-hmm.
Virginia is a little bit more difficult because if you don't do 300 deliveries a year, they pull your certificate of need. They want to make sure that there's enough volume so that the obstetricians maintain their skill set. And you have to have a residency trained pediatrician on staff at the hospital in order for the OBs to deliver. And then the OBs don't want to come because they don't want to be an OB with no backup and the only OB in town. So they want 2 and they're enough volume for 2. And then which I understand all of this, they are not so comfortable with the CRNA. The hospital only had a CRNA, no anesthesia department, because they couldn't afford an anesthesiologist. That people talk about you're abandoning the rural community, you're doing this, you're doing that. And I have a name, but I won't mention it because George will have a seizure. But when he talks on LinkedIn about the pediatricians suck and the pediatricians abandon the poor communities and the pediatricians don't play nice with nurse practitioners and the pediatricians this and the pediatricians in silos and the pediatricians in that, I'm like, dude, you get out your fancy attending Pete's ER desk at a children's hospital and spend a week in your practice or in Lebanon, Virginia, where you're seeing the father with ADHD that the family practice sent to you because they're not comfortable medicating him. And all of a sudden, the family practice doctor, there's a friend of yours that's covering the ER calling this, or the rescue squad just called. We got a 3-year-old in status coming in. Did you run over and help me? Because I feel really uncomfortable. They're like,
I haven't had that
okay.
one yet, but I always wonder if that's going to happen. We had a carbon monoxide scare where I think the kindergarten in the rural schools had a high carbon monoxide. So we got all the people loaded up. We lined everybody up when they came in on the ambulance and checked all their levels. And fortunately, there was just like 1 or 2 adults, I think, and maybe one kid that had to stay overnight. And that was it. But no status.
And I'm old school, so I believe in relationships. So when I moved to Lebanon, I went to Roanoke, Virginia. It was a 2-hour drive. Carillion had a PICU that was run by Dr. Kraft, who had been a neonatologist before. And I went toward the hospital. We had lunch together. I told him where I was and what my limits were. And he said, okay, we got your back. Just like you said. Well, if you have a critically ill neonatal case, this is the number you call. And I met the neonatologist, and I did have 1 or 2 that I had to transfer, but these were the good old days of medicine. You knew who you were talking to on the phone. And they're like, yeah, Herb, we got your back. Okay, you did this, you did that. Let's think about this other thing. And they didn't have a helicopter, but the Virginia police did have a helicopter, and they would send the police helicopter to pick up the sick kid and move him over to Roanoke.
Oh, wow.
But it was too small of a helicopter because when I trained in Michigan, I flew in the helicopter. It wasn't a Huey, it was too small, so you couldn't go with the kid. So you basically stabilized him, put him in the police helicopter, and they flew him out.
Yeah.
But and this is in 1992. It's a different set of responsibility, and you're not giving yourself enough credit.
Definitely not giving yourself
It's
enough.
a lot of work.
One of those relationships I see as I'm longer and longer outside of residency is all the people I train with in Wichita that really gave me a network. And a lot of them are still there, but I see the NICU where a couple of them have retired and a couple of them are still there. So it's nice to see that when you call them in the middle of the night, you're like, okay, I'm not joking with you.
Yeah.
This is a baby that needs to go, and they know it. And I give them a checkout, and it's there, unless there's some circumstance where they can't help us, they're right there and they're on their way.
Yeah. We used to have that kind of relationship with the hospital near us. It's not a rural community, suburbs, but they had pediatric physicians in the ER. So you used to, how many times I would call, I would say, Helena, I am sending you this kid. I don't know what he has, but good it's not. She knew to take that seriously.
Yeah.
Now, those guys are no longer in the emergency room. They decided they're going to have adult medicine take over. Maybe they have 1 or 2 pediatricians left. You don't know who they are. They don't even want a phone call from you. We get them on the receiving end. The nonsense gets admitted, and things that should be admitted get sent home. It's like 1993 again. It blows your mind.
Yeah, we talk about this a lot. The lack of relationships is really hurting us as professionals. It's also hurting our kid.
Yep.
It's hurting society as a whole. We need to get back to
relationships,
but more effective and have good relationships. And we need to have people be mindful not to ask us to do things where we're at our limits of our knowledge, because it's not safe for us mentally, and it's not safe for the patient. I always say that the most dangerous clinician is one that doesn't know the limit of their knowledge or experience. And there's a lot of people like that, a lot of Yahoo people I can take it up.
We've had some people come and go in our community. I'm glad they're no longer doing one of them has left town. I won't even say what their specialty was, but I just felt like they were the cowboy. One other thing about there's relationships is resources. And we have pretty much, for a small hospital, we're very fortunate. We have like the foundation, which is a hospital's philanthropy. They helped me with the student loans when I got here, and I've been on their board for several years now. And I try to help encourage those people who donate to this organization to see that the money they're donating is going towards things they can use in their community. It's not just, let's patch the hospital, let's get them a new service. We have a cath lab here now. It's just during the daytime. But one other resource we had that was difficult, you can't buy, is blood. Our lab didn't need an inspection a couple of years ago. And so we didn't have deliveries for 5 months. And so we had our OBs. They went to a different hospital about 20 minutes away. And not that I was never called to the hospital there, but at the same time, it was just it showed you how quickly things can go sideways or go down. We have 1 day a month where our nurse anesthetists can't cover, maybe 2 days a month now. And they want to cover, but I think there's just 3 of them and they each do 24-hour coverage. And most nurse anesthetists, I think, don't want to be 24-hour call. They want to come in at 5 a.m, do day outpatient surgery clinic, and then they want to go home at 3:00 and punch their time card. So we're really having trouble finding those kinds of people around here when the other ones retire.
Yeah, and it is a political term, but it takes a village. You cannot deliver babies as a pediatrician in the parking lot at the garage of your home. It's not possible. You need anesthesia, you need OB, you need the lab, you need blood supply, you need oxygen, you need a backup plan. And if one of those scaffoldings falls, doesn't matter how much you want to help, you can't.
We had a panda warmer, which is really handy, but we had a C-section room and we have 2 delivery rooms. And so that one panda warmer would be in one room. So if we wanted that for the resuscitation, and we didn't want the old clunky resuscitation bed for the newborn, we just had to deal with it sometimes. And okay, where is this plug-in on this resuscitation cart? Or how do you plug in the oxygen on this thing correctly and get the blender working? And it's just, but now that's been all corrected. We've gotten these panda warmers or something similar. And so it's just, I don't know, I guess it keeps you on your toes, but you don't want to be on your toes when you're in the middle of a baby born and respiratory distress.
No. You're doing a great job. You're doing a great job for the community and the kids out there. So I didn't have this. We barely had. So in 1992, we had Netscape through America Online. That's at the dial-up service on a Mac laptop. But now you have the capability of adding some technology to your office to help you mitigate the distance between you and the subspecialist. Are you an early adopter of some of this technology?
We did do a lot of telemedicine on our end for during the COVID time. We still have it, a lot of ADHD or like simple problems. But when it comes to dialing in like a subspecialist, we did have, the community has, not our hospital, but the one I practiced in before has like this robo-doc that would basically be a hospitalist, like a tablet on I don't know, it was one of those technologies where I think 10 years ago it sounded great. And then I'm not sure it's as good as having a hospitalist in-house, but they could admit a patient at night with a video screen and a camera and a couple instruments. I wish we used it more. I know our federally qualified health center we have down the street, one of my colleagues is a family physician here, and they have that for more of I'd say mental health. They have those rooms with the teleconferencing, like the large screen and the camera. I'd be open for that. I have, in terms of other screenings though, I had an employee whose family has type 1 diabetes. And so I was over in Miami at that Coral Gables conference for Nicholas Children's, and they had that there as a display, like what labs to order for trying to catch early onset diabetes before it manifests with symptoms. And I want to get that started. I have the labs I can order. My plan is just to screen people who have a family history of type 1, not every child, because that just seems a lot right now.
So I have a question for you. I have many questions for you now that you opened Pandora box. Because when I talk to people that are not pediatricians and that have never gotten out of a big pediatric hospital emergency room, I say every practice in America is different.
Yep.
The first thing I have to ask you, Todd, is, does your Medicaid MCO pay for the lead and the hemoglobin screens in the office, or do you have to send them over to somebody to draw them?
So we had to send the leads out before we have a hemoglobin point of care, but we worked with one of the 3 Medicaid providers, and it's Aetna is the one that did it. They found a grant. So we have a lead care machine as of January. So now we're using that. As far as I know, it's cost effective. We've had some lead poison, nothing like what we saw on some of those cases for lead poisoning, like where they were over 100. But we've seen, our public health department has seen at least 2 children with levels over 40.
Yep.
And so now I think they're really pushing that in terms of this preventative care for everybody. And I think that the Medicaids are also finding the funding for that too. So we've started doing that this year. We did the hemoglobin for many years, but lead was always too expensive for us to do here.
Okay, so now you can do the hemoglobin and lead. And are you doing it we do it out here at 1, 2, and 4. That's just, I know WIC requires it and they want it before they enter school. A lot of it is because of what the state regulates. I don't know, do you do it only at 1 or do you do it at 1 and 4?
I usually just do it at 1, and then if they're going into, say, we can't find the results from 1 and they're going into that early, like the Head Start program at 3, we'll do it again. Obviously, if it was elevated, we get it a venous, but yeah, I wouldn't say we screen at 2. We just do the.
And what do you do about the case that you don't screen at 1 and they come in at 4 and they're positive with an elevation of the lead 60? You got duck.
What do you do now?
What do you do now?
Besides 1 and 2.
Yeah, and if you don't do it, it's a problem. It's a problem.
And I'm sure I've missed those people. You try to catch all those things.
Yeah, it's a problem.
And so the reason I'm asking you is so as you think through diabetes and the particular spot in which your practice is, you don't have a PZR, you don't have a PICU, you don't have a pediatric endocrinologist. If I was sitting in your shoes, the last thing I want to deal with is a child with DKA in the emergency room in the middle of a snowstorm. And I'm sitting there having anxiety about how much insulin to give him or her and how fast to push fluids. I would be testing everybody for diabetes just to know which ones are the kids at risk, just because of my particular circumstances. It's just, I know you tested for 2. I know you need education. I know I need to follow your hemoglobin A1C. And when you become dysglycemic, there's no other option, but you got to drive up to Wichita and see the endocrinologist.
Yeah.
But to me, that seems a lot less risky now that I have it available than if just wait for the kid to get DKA. Because you have to keep in mind that 85% of children with diabetes don't have a family history of autoimmune. Even if you take the strategy, which is the commonly accepted strategy now of only screening the ones with family history of Hashimoto's, diabetes, or celiac disease, maybe Crohn's disease, you're going to miss 85%. If you're in Long Island, where there's a pediatric emergency room, PICU, endocrinologist 3 miles from your office, it isn't pretty, but you got a lot of resources. And the reason I was asking you whether you could do the lead or not in the office is because if you're already doing a sample, finger stick, or hemoglobin, for example, 1 and 4, you can get these cards and then you blot it like the newborn screens in your office and you mail them out and they give you the results of the anomalies.
Oh, okay.
So you can work it into your workflow. It's all about making it easy so that your staff doesn't have more work to do. You don't lose money at it. And you can identify the highest risk patients quickly and avoid having the call of this kid's in DKA at 3 a.m.
That's a wonderful work plan, policy, or whatever. But what do you do with them when they're positive?
Simple. They're positive. If they're not dysglycemic, you follow them along with hemoglobin A1C every 3 months. As soon as that changes, then you have to send to Pete's Endo that will help you manage it.
But his Pete's Endo is 3 hours away.
That's just responsibility. When you choose to live in a small rural community, you're going to have less access to restaurants, movie theaters. It's a compromise. Life may be easier, nicer, but you chose to live there. So now you're going to have to choose to drive to see the subspecialist. There's no easy lunch. But that's one way to implement that, which I thought about a lot for pediatricians in more rural communities without any support. No. Have you ever thought about using bedside ultrasound?
I think the main things I thought about using it for, maybe venous access, we have people that we can get venous access. And we're right next to the hospital, so usually that's fine. But getting like an abscess drained, a lot of times if I have something that's pretty severe, I haven't done it I guess I haven't tried it on one in the office. It might be worth trying. I haven't tried it though. I mean, just the one at Coral Gables at the conference, they had a sample there to try.
Yeah, the photos, that's a butterfly. Because Susan's Rhoda is incorporated in their office in Chicago, and she's learned to diagnose pneumonias, constipation, and some of the other people use say you can actually see the fracture line if you get good at it. And it seems to me like if I was in a more rural area where it's not so easy to get into a pediatric radiologist, these little things would help my life quite a bit.
I think stress fractures would be good we have a lot of teenage athletes. What do you do in rural Kansas? You do sports or something to keep yourself busy. And there's not, like you said, there's not really movie theaters. But yeah, they do a lot of athletics and we get a lot of sports injuries.
Yeah. I learned both in the ER and in rural practice, and it's gotten easier, right? My good friend was an orthopedic surgeon specialized in the foot. He says, it's a waste of time to get a fellowship in foot and ankle anymore, isn't it? Why, Sam? He goes, it's pretty simple, Herb. Any foot that hurts, put them on a camp boot. And now you can get the camp boots on Amazon. They're $40. And they have pediatric camp boots. So the first victim of orthopedic foot surgery is if it hurts, immobilize it. The second one's X-ray. X-ray everything here. Even if they can bear weight, X-ray it. No one will ever fault you for X-raying. And then wait 2 weeks and re-X-ray them because you will see the hairline fractures as they start calcifying. Then you take them off of the boot and send them to physical therapy. Because if you do that, you'll never do wrong for a patient. And if you fail those 3 steps, then they need to see a sports doc. Right. And it's a genius, very small, practical, this is what you can do and you'll do no harm and everybody will get better. I like that. How about screenings, computer screenings? Do you use
chats and we use ASC?
Well, yeah. I'm thinking like the eye exam. What's that company?
Oh, the eye one that's a area of, as far as unless it's changed in the last couple of years, Kansas doesn't pay for those,
check
kids. And so I do the standard endoscope, ophthalmoscope eye check for a strabismus or for a lazy eye and for amblyopia. So I do that and I send them to ophthalmology. But again, they get at 3 years old, the state of Kansas gives it to the preschool screening. They do them there. So it's taken out of my hands. And when you mentioned getting a butterfly ultrasound, I thought an eye check machine would be nice too, but just for one doc office, I don't know if we can really.
I don't know what it costs. Yeah.
And the state of Kansas doesn't really pay for that particular, as far as I've checked in the past, they don't pay for that test. I can do like a wall chart check and get whatever, few bucks for that. And so we do that when they're about 4. And then before that, we just check for any kind of sign of a lazy eye or vision problems.
And how about things like we interviewed somebody from Cognoa and they have this app, but it's not covered by most Medicaid programs. But you can take 2 short videos of the kid and somebody reviews them and they confirm the diagnosis of autism as early as 18 months. Is that something that you see a lot out there, autistic kids?
No, I would love that. We have our early childhood intervention, I call it pre-K, but anyone from 0 to 3, our county program is very good and they do help a lot for me. I refer a lot to them, but they also find a lot of these kids that there's still ones that we miss though. And I would love to have more tools. MChat helps, but sometimes the language barrier there. I had somebody who's more Spanish speaking family. They speak some English, but I always thought they were just teaching their 2-year-old Spanish and it gets to be like 3 or 4s in preschool. And they're like, oh, he's on the spectrum and pretty significantly on the spectrum. And it frustrated me because I felt like I did what I should, but I didn't catch it earlier.
Yeah. And I think again, and I say this a lot, the problem that we have is lack of payment. All these things can be put into our workflows if we get paid for the time we're spending with the patient. We get paid to train and stay proficient. Because if you're not using an ultrasound machine but once every year, and you're going to, at least I would have to go to a course, 2 or 3 days somewhere, and learn how to use it and have someone teach me what I'm seeing, and then do it often enough in the office and have somebody review what I think I'm seeing until I actually become proficient.
It'd be nice to have a skills refresher, especially for if you're more rural. I know as I finished residency, they were starting to do more these tracks where you could be more like, I want to be a hospitalist, or I'm going to be a rural pediatrician. So I need more like skills that maybe I could refer to the neonatologist, but I'm going to be in a rural setting. So I need to have that skill. So we're going to do more procedures for you or whatever. It'll be nice now, 10 years, 12 years out, to get like a refresher. You go to these conferences and they're more like intellectual refreshers too.
Yeah.
Yeah.
When I was in Michigan, one of the attendings was Dr. John Whittinghill. I don't know how old he was because I was 23 years old, and he might have been my age now, but he looked ancient, right? Because when you're young, anything beyond 30 looks like they might die tomorrow. And a great human being. And he started his practice in Billings, Montana, the second pediatrician in Billings, Montana. Did everything. Went to the NICU, went to the farm, stitched faces up, everything. And he was salty, and he had the funniest humor and COPD. And he would say, Herb, if you're a good doctor in a community, half of the people want to walk on the same side of the sidewalk with you and hug you. Almost the other half wants to walk on the other side of the sidewalk because they hate you. And a few of those want to spit in your face. Mm-hmm. He said, that's what happens when you do good. You got to learn to live with it. Wow. And I'm like, it's not about being liked. You got to do what's right. And when you tell people bad news, or when you disagree with them, or you find a child that's abused and you call CPS, those people aren't going to like you. And you cannot let that bother you as long as you're doing what's right. And then the other thing he used to do, he said he kept his skill set. I don't remember which children's hospital, but there was a children's hospital that took rural physicians, and he would go for 1 week and round in the morning with attending and the residents at the children's hospital. And then he would stay every third night and do calls with the residents for that 1 week. Because he said what the attendings teach the residents in the morning is all theory, nonsense. They don't know what they're doing. What you really learn is in the middle of the night, the patient's sick, and the third-year resident is doing new stuff that you didn't see when you trained. And he said that was the best way to keep your skill set and your mindset and you should never do. I don't know of any children's hospital that offers that nowadays.
Yeah.
But that would be a phenomenal course. 1 week with the residents in Miami Children's at Nichols, or what Cincinnati Children's, I don't know, Kansas City.
Children's Mercy or somewhere, yeah.
Yeah. But it's fascinating how time has passed me, but the older I get, the more the old lessons apply.
That's what made you a strong physician.
Yeah, all these great experiences.
Yeah, it was called education. You stayed up at night. You saw a lot of patients. Not seeing patients doesn't make you a good physician. I think it takes, and just reading books doesn't make physicians. It's doing things. I listened to the sad part. I had one physician that joined our office right out of residency. And then shortly into the year, she said to me, do you know that during my entire residency program, I did not make one decision by myself? And then I wondered why our office was so complicated for her. That's pretty sad.
Yeah. I lucked out. I just had a tremendous amount of great mentors. I just was very blessed.
Yep.
Yeah, we had an attending who had come from Atlanta and worked at Children's Mercy, which is a very large, and not saying bad things about either of those places, but when she came to our residency as our attending, in Wichita. She's, wow, you guys don't have any fellows. It's just you guys. You get a lot of hands-on stuff here because there's 5 residents a year. So we have 15 of us plus a couple med peds residents and med students. And so maybe we might have somebody on a trend, like a intern year, maybe a surgery resident on intern year comes on. So it was just a really small group of people being trained in this hospital.
Okay.
And just quickly, what is the most challenging thing about practicing in rural America?
I think, like you said, you need those relationships. I think a lot of people don't realize that. They just want to clock in and clock out. I think until you get to those relationships, they're not going to tell you the things that you need to know to help them. They want to hide things, or they don't really realize it's important, that piece of information. It applies other places, but I think around here, and there's a lot of gossip too in small towns, people just need to, once you earn that trust and they show that you really are genuinely concerned about them, not that just you're the fancy doctor in town. Because I am there's not a lot of people with graduate degrees here. So I am a little different person, but they see that you're a real person. They really attach to that. They know that, okay, I can trust you and we can make some progress together.
It almost sounds like, if you remember that movie, Doc Hollywood with Michael J. Fox, ended up with his Lamborghini in the small town, and the guy did not want to leave.
Yeah.
It's just supposed to be a plastic surgeon in I don't know, in California somewhere.
Mm-hmm.
That's you, Doc Hollywood.
Yeah.
Yeah.
Me and Michael J. Fox.
Do you find your decision to go to Oz rewarding? Would you do it again? Would you follow the yellow brick road down to Kansas once again, or would you go to fancy California?
Yeah, I've thought about that over the last couple of years. And as a kid, I really Mother Teresa wasn't very young when I was a kid, but she was always on the media and just talking about helping these poor kids in Calcutta. And I thought, maybe I'm not helping that kind of child, like the one with cholera and no vaccines, but at least I feel like I'm making a dent in a community where I'm near where I'm at, that's close by. And I feel like it's definitely a community that has lots of needs. So I feel like that does feel important to me. And whether anybody remembers that or not, at least I feel like I did what I could for them.
Okay. People will remember it. You'll just be surprised how people remember it. You won't know, but people remember.
People remember you.
Yeah.
Yeah.
And I have a very curious question. How did you come across the podcast to begin?
Oh, let's see. I think I found that CHOP had a primary care in pediatrics, and I think I was just searching on my podcast app for Pediatrics. I don't know how I found it, but then I thought, when I was in training, we did have a lounge and people would talk, and I'm like, this is a great idea, because people would just, I'm by myself. I don't have anybody in my office except once a week we have a nurse practitioner. I can't really reminisce about residency with them. I could on social media, but I just prefer that face-to-face interaction. I like hearing you guys talk. This reminds me of the person I am, that I like to have those conversations, talking together versus text snippets or something. So that's why when I saw it and I listened to the first episode I got to listen to, I really was hooked.
Yeah. Remember to share it, tell your friends, subscribe, and all that other good stuff, because we want to get the message and elevate great physicians like you. You're downplaying your role, but let me tell you, you're a hero.
You're doing tremendous work. You're an amazing human being.
Yep.
I'm so blessed to have met you in Miami.
Yep.
Yeah. That was a good time.
Yeah. So are we going to see each other in Nicola's 60th postgraduate course next year?
I think so. My other big one was to eventually hit NCE, the big.
Yeah, but
never
not
been to
this
that.
year. It's in Orlando.
It's Orlando.
Unless you have young kids, you want to go to the parks.
I like Nicholas. Maybe I can get my wife to come this year, and with her schedule, we always try to coordinate with her job, because it's a college schedule. So whenever classes are out, she's free to do whatever.
Yeah.
Yeah.
Yeah. I think next year NCE is going to be in Denver.
I think that's right.
And then the year after that is going to be San Diego. So
I'd love to do both.
Yes. I'd love to see you again.
Likewise, Herb. I had a good time at that conference. I like talking to you guys today. I really had a lot of fun just chatting about what goes on.
Thank you. Thank you for your time. You're doing an amazing job out there.
Great. Well, you guys have a good day, and thank you again.
Thank you for listening. This has been a production of the Pediatric Lounge. On the show notes, you will find links to our co-host and other important notes, as well as a timetable of the topics discussed today. Don't forget to follow us on social media and subscribe to wherever you listen to your podcast. Leave us a great review as it helps us greatly. In the meantime, we will see you next week. The Pediatric Lounge. The conversations are not intended as medical advice, and the opinions expressed are solely those of the host and the guest.